Good morning to all of you. Delighted to be here at IAPCON and GCRI to talk about my favorite topic. I'd like to start off by clarifying a very common misconception that just listening to music is not equal to music therapy, which is not equal to music medicine. All three are three different entities, three different terms. They mean three different things, so they must not be used interchangeably. Music therapy, as defined by the American Music Therapy Association, AMTA, is the clinical and evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by, very important, credentialed professional who has completed an approved music therapy program. Music medicine, on the other hand, is a term used when patients listen to pre-recorded music that is offered by a medical professional. Is musical perception innate or acquired? This is very interesting. This is the latest study from 2024. So this study, in 2009, actually two research groups from Netherlands and Hungary conducted a study in which 14 healthy sleeping neonates were provided with drum rhythms, occasionally omitting a beat. The sound sequence they provided was this. The infants displayed an anticipation of the missing beat as their brains exhibited a distinct specific spike signaling a violation of their expectation when a note was missed. And in 2015, the same researchers repeated the study among 31 healthy newborn infants, and their EEGs were recorded. The research published this year in 2024, and they report converging evidence on newborns' beat perception capability. Interesting thing is that in 2018, when they did the study in monkeys, they found no evidence of beat processing, showing that this beat perception is unique to humans. Now coming to the music processing in brain. So music is bilateral. It is not a single location in the brain that analyzes / processes music, but multiple circuits of computational hubs. And music processing starts in the auditory cortex. So at auditory cortex, that's the first stage of listening to sounds, the perception, the analysis of tones. And from there, the signals are sent to multiple circuits / computational hubs, and each component of music is processed / analyzed separately. So the locations of these computational hubs are prefrontal cortex, and specifically Broca's area 44 and 47. And at Broca's area, at prefrontal cortex is that, creation of expectation, and then there is violation or expectation, violation / satisfaction of expectation happens. And then coming to motor cortex and cerebellum, these are the two areas involved in mediating movements. So when you listen to music, when anyone listens to music, there is a tapping of your feet or snapping your fingers with the rhythm, right? All of that, or playing an instrument. So basically anything related to finger movements or bowing the violin. So anything related to the movements. Then coming to sensory cortex. So sensory cortex is involved in tactile feedback from playing an instrument or dancing to a particular tune / rhythm. So it's like, your fingers playing a piano or something of that. So anything, tactile. And then visual cortex. So visual cortex is involved in reading music. So a pianist is reading from the notes or a sheet of music, right? The notes, or visually. And then, or otherwise an audience or watching a performance, right? Watching the pianist's fingers moving. So that. And then when the brain was cut open, it was observed in the second picture that music activates well-known pleasure centers in brain, nucleus accumbens, amygdala, and ventral tegmental area. Very interestingly, these are reward centers, which is activated by sex and drugs. And there is hippocampus, which is involved with the memory of music and the musical experiences, childhood memories or memories in general and contexts. This is an image published in Lancet Neurology. It's from a review and from the year 2017. So there are three possible mechanisms for the rehabilitative effect of music. So the first one is from the functional neuroimaging studies in healthy participants that have shown that music induces widespread activation of various networks in the brain and correspondingly increases blood flow through medial cerebral artery because of autoregulation. And this provides favorable circumstances for recovery in general. And music therapists actually use this in stroke rehabilitation. So what they do is, music therapists will encourage the patient to enter into a particular rhythm and ask or encourage the patient to move the affected limb, be it feet or be it hand. So enter into a rhythm and encourage them to move to that particular rhythm for weeks, and that's how many randomized control trials from across the world, across decades have shown that this entrainment is particularly beneficial in stroke rehabilitation. So basically what happens is, after stroke, the neuroplastic changes associated with functional recovery are activity dependent, and musical activities are similar to an enriched environment facilitating recovery. Music actually also produces measurable cardiovascular and endocrine responses, but at the same time, it's also, there is some duality. So when a patient listens to relaxing music or soothing music, the cardiovascular responses such as like heart rate comes down, respiratory rate comes down, and stress hormone, which is cortisol, that also comes down. But at the same time, when the patient is listening to some music which is triggering, or an exciting music, or like rock music, all these goes in the other way. So heart rate increases, respiratory rate increases, stress hormone, cortisol increases. So now, what music relaxes somebody and what music triggers somebody is very personal question. So that's what globally we encourage patients. So, ask them like, what music is your favorite? Because I might find one music relaxing which might be triggering to someone else, right? So, and that's mainly because music is very innately intertwined with autobiographical memory, so it's very important to ask patients. Very interesting study. Brain-derived neurotrophic factors, BDNF, is a neurotrophin that is involved in synaptic plasticity and survival of neurons. And BDNF and its receptor, tyrosine kinase, receptor B, are widely distributed in the brain in the areas that I mentioned earlier where music is processed, which is hippocampus, auditory cortex, cerebellum, and midbrain. So what happens is that BDNF has been reported to play an important role in modulation of anxiety. So there were plenty of rat/mice-based studies that showed the association between BDNF levels and anxiety in the last decade. Here I'm showing one of the latest studies from 2023. So in the bar diagram, you can see that in comparison to control, music group, those who listen to music, had an elevated level of BDNF. So what BDNF does is that, this study reports that music may restore HPA, hypothalamus pituitary adrenal HPA axis homeostasis, preventing three things: one, oxidative stress; two, inflammation; three, neurotrophic factor deficits. Again, very interesting study from 2022, published in Science, prestigious journal. First demonstration that music is effective in preventing depression-like behavior in animal studies. The neural mechanism may be that music protects against the disruption caused by oxidative stress and increased inflammation levels caused by severe stress in mice. Music also prevents the HPA axis from releasing large amounts of corticosterone due to overexcitation, which leads to downregulation of BDNF. And finally, music protects neurons from loss and maintains homeostasis. It's very interesting. 4 years ago at IAPCON, when I came to Guwahati and presented the same topic, I didn't have these data. This is, as you can see from 2023, most of the research that I cited here are from the last few years. It just shows that the frontier is being pushed, the music-based intervention studies. So there's a lot of interest right now. There's a lot of funding, NIH-based funding right now. So an advancement in technology and imaging studies in general has accelerated the exploration of music and brain, or even in clinical research as well. So it's very interesting, because last time when I came, 27th IAPCON, I said it's mostly attributed, all of this music's beneficial effect in anxiety, stress, and pain are all related to, in general, stress reduction and, reduction in cortisol. I did mention about the corticothalamic tracts, which I'm going to mention later, but then that was still a postulate. But now we know it's kind of, it's not really just the distraction, and it's not really just the stress reduction. It does have some further implications. This is what I was talking about. So pain relief by sound is not purely attributed to stress reduction and distraction. Again, latest study, 2022 study, reveals that corticothalamic circuits underlying sound-promoted analgesia, which is pain reduction, by deciphering the role of auditory system in pain processing. All bench research up until now. Now we are going to talk about the clinical implication of music-based interventions in palliative oncology. Most of these studies are randomized controlled trials and meta-analysis on randomized controlled trials. I'm highlighting only some of the most relevant ones. There are many more meta-analysis on RCTs. I'm just focusing it on the palliative oncology and palliative care aspect. So as you can see, music-based interventions have shown to reduce anxiety, depression before, during, and after cancer procedures. Relief of acute procedural cancer pain, improves mood, alleviates pain, improve overall quality of life, effectively reduce the incidence of anticipatory chemotherapy-induced nausea and vomiting, mitigating cancer-related fatigue. Very interesting study from 2021. 81 RCTs, which included 5,576 participants. Music was beneficial in reducing anxiety, depression, pain, fatigue among adults with cancer. It was again helpful in patients with hematological cancer in reducing fatigue. I'm sorry, I think some of the words got cut. Improving quality of life, relieving anxiety during breast biopsy, and finally helps in spiritual well-being of palliative care patients as well. Question is, do we have music therapy in Indian clinical settings? Short answer, no. Why? Because I started with the definition of music therapy, and despite housing two ancient Indian classical music schools, which is South Indian Carnatic and North Indian Hindustani, and popular music, folk music, hundreds of musical instruments, spiritual music, independent music, devotional music, all kinds of music. We do not have music therapy, national medical regulatory body accredited music therapy training programs or guidelines, and hence we cannot use the term music therapy. I'm not saying when anyone else provides music to patients or caregivers, that doesn't have any value. I'm not saying that. All I'm saying is the term music therapy is a profession-specific term, just like speech therapy or a nursing or a doctor or a physiotherapy or dental therapy. So that term is a profession-specific term, and it must not be used to describe interventions delivered by healthcare professionals who do not hold MT degree, music therapy degree board certification/license, because it conveys a specific clinical and academic training level. So what can we use? Music medicine. That would be the term appropriate to use in the context, in our context. We did, as part of my PhD, a systematic review meta-analysis on randomized controlled trials on Indian classical music with the parameters pain and anxiety in hospital settings. Why hospital settings? Because when we analyzed the randomized controlled trials done in Indian classical music, only one was in cancer setting and two are in dental setting. and one is in cardiovascular. So there is not very many research randomized control trials available to focus it on a particular clinical population. So thus we had to go for a larger umbrella, and that's why the hospital settings. Now, the findings, however, are limited by lack of research in this area. Paucity of randomized control trials, biggest challenge. And among the existing randomized control trials, it was of poor quality in terms of lack of masking / blinding at the investigator level, analysis level. There was bias, there was absence of critical details, including the Institutional Human Ethics Committee approval, randomization process. It's called randomized control trial. So details on randomization and sticking on to the guidelines, or concealing, details on the concealing. So it was absent, all of these things were absent, and many more. They were just highlights. Methodological heterogeneity, subjective participant reported outcome measures were used, and poor reporting. About poor reporting, I'm going to briefly touch upon at the end. So current challenges in India, so there are three. Lack of high-quality randomized control trials on Indian music among Indian patients. A possible solution to that is incorporate multicultural, local / indigenous music in cognitive music science research and randomized control trials. Local music. Second one, absence of national medical regulatory body accredited academic training programs for music therapy in India. So for that, greater implementation efforts are required in forming a professional organization for music therapy to set guidelines for an appropriate training curriculum. 2, guidelines for regulations and credentialing procedures for providers. 3, poor quality of existing randomized control trials in music-based interventions, and poor reporting quality. So for that, the possible solution is conducting research workshops. Potential future directions in 4 domains. Basic and mechanistic research. In that area, I think conducting research on interaction between music and the brain and Indian music, based on focusing on Indian music. Translational and clinical research, encouraging randomized control trials on Indian music at academic institutions. People sitting here at medical schools, medical students, palliative oncologists, physicians, oncologists, many people are really interested in inculcating music into their clinical practice. So there should be an institutional / academic institution level encouragement on this by providing these workshops or funding. The third domain is methods and outcomes. Instead of quoting or citing a particular patient, we gave music to this person or a group of people and they loved the music. That's very important, and that's adds value. But at the same time, we would need longitudinal, prospective, long-term studies to assess the outcome of musical interventions. Rigorous reporting, meticulous reporting of interventions, methodologies, research, which I'm going to briefly touch upon in a bit. Establish standardized and personalized outcome measures. So when we analyze the randomized control trials from India, anxiety were reported in different versions. So it's very difficult to meta-analyze all of that, and we had to exclude those studies. So it's very important to standardize these outcome measures. Capacity building and infrastructure, very important. Research funding and multidisciplinary research collaboration. Funding is more than an administrative thing, but I guess multidisciplinary research collaboration is in your hand. You can actually reach out to colleagues, neuroscientists, musicians, physicians, oncologists, palliative care physicians, all of them, and do collaborative research. Third one, again I'm reiterating over and over again because it's very important, National Medical Commission accredited professional organization for music therapy. In December 2023, I attended the NIH, National Institute of Health, the US, their workshop on music and medicine. And whatever I said right now as challenges from India, in terms of research reporting, is something mirrored or reflected in a global scale as well. Many countries, even in the US, where music therapy has been established since over the last 70 years, they also find a couple of issues with the reporting. So reporting, what I'm trying to say is when you conduct a research or randomized control trial, when you write it up as a manuscript and publish, there were many, they were not really clear. So I'm going to talk about it right now. So Sherry Robb and her team came up with these guidelines in 2011. So these are the things it's like a checklist to actually focus on, not just while writing manuscript, but when you are writing the proposal and conducting the research. So now coming to, the updated version of this guideline is going to get published in 2024 in a few weeks. But yeah, we have right now 2011, so we'll use that. So intervention theory, very important, rational. Why are you using this particular using? So in music, for instance, Indian classical music, okay, why this raga? Like, is it because the investigator thinks it's, it's soothing, or, what exactly is the rationale? Or you're using a popular music, why is it? Is it because it's patient's choice, or is it because, the pacing, it's a fast rhythm or slow rhythm? What exactly it is? Second one is person selecting the music. Very important, as I said, music is intertwined with the autobiographic memory, so it's important to include all of that. Like person selecting music is very important. So now, is it pre-selected by the investigator, or is it participant selected music from a list of music the investigator provided, or participants selected their own collection of music? So it might sound very silly because it's after all music, right? But imagine in a way that if you're giving a drug to a patient, isn't it important? The components important. Isn't the composition important? Isn't the route important? Dose important. So like that in any interventional study, even if it's music, it's very important to bring clarity. Then coming to the music, like is it published music or improvised music? If it's original music, then like the form, elements, instruments. Again, it might sound very silly, but when we analyze the randomized control trials from India, it was like we just gave this particular music and the results were this. So clarity is very important. Delivery method, like who delivered the music, and was it delivered using a headphone or speaker? So there was the study published in this prestigious journal GCRI. It's very important even to include the brand of the headphones that you use. And then who determined or controlled the volume? Might sound very silly, but decibel level, volume, very important. And who controls the patient or the investigator? Intervention materials, intervention strategies. So was it just listening to music, or songwriting was involved, like more active intervention or improvisation? Lyric analysis, rhythmic auditory stimulation, so what was it? Now intervention delivery schedule, number of sessions. It might sound again very silly, like who will miss this information, critical information, but many randomized controlled trials did not even have this information. So the number of sessions, session duration, session frequency, was it once a week or once a day, including the practice sessions. Interventionist, again, qualifications and credentials of, it was just written in some research, some article, nurse provided, or somebody like investigator provided. Okay, what is the qualification and credentials of the interventionist? And then how many interventionists deliver the same, how many interventionists deliver the study conditions? And in that case, treatment fidelity, setting, unit of delivery, very important. All of these, sorry, it might sound like drinking from a fire hose. I'm sorry, overwhelming information, but if you would like to know more, I'm ready to give out the handouts. Thank you so much.
Thank you, Tara, for your very well knowledge. It was very interesting and very new to us. In private practice, we try to give all these things to patients. By our own knowledge, like in morning we do advice for rag bhairav and all these things, but these therapies are possible and available. Many of us do not know that, and quite a few percentage of patients are ready to accept this and pay for this in a private practice. So we need to spread this awareness. Yeah.
Thank you.
Thank you.
Question from audience. Comments? Hello, thank you so much for such an interesting and intense explanation. I'm into the clinical practice, but I'm a healthcare clown, so I share a little all the challenges that our profession has. But I would like to go a little in a little line because it has been a lot of studies, lot of challenges that we have. My question is, how is the situation actually, the collaboration with palliative care medicine? No? It's like, if anyone is doing, how are you doing? Because I think if something comes to me in all the congresses, like we are talking about teamwork, and that is human by human. So I would like to know something more specific. Is this done? So if it's a group of or individual music therapists doing something in India, and how can be one session, for instance,
in Indian context? You know, as I said, it's not yet a professional therapy yet, but there are many hospice places that I know they are playing music to patients one-on-one and also in sessions. But again, it's very difficult to comment on it because it doesn't have that, you know, the NMC accreditation. So it's very difficult to comment on that, because if you ask them, they would say yes, it was helpful to patients, but well, unfortunately, it's very difficult to comment on something because it doesn't have a lot of objectivity. So, yeah. But I guess it's a very, thank you for that question, very important question. But I guess for now, because I think with the administration level bringing up all these infrastructure changes would take a lot of years and time, it doesn't happen overnight. But I would encourage the physicians and healthcare providers to ask your patients, be it palliative care or oncology, ask your patient what's your favorite music, and then play it whenever possible, particularly doing a procedure or bone marrow biopsy. All it takes is one question and you can, so that's the practice-based thing I think that we can do at this point.
Okay, and I'm sorry, I have another question. Because it's like the hospital or the medical or physicians or whatever has to invite the music therapist or has to the responsibility. Have you considered, like, what I get from all the story of palliative care is like it was always starting from zero in a little desk, starting with anesthesia programs, and then we have the IAPCON and these things. Have you considered to start maybe going to a small unit or whatever? Or let's start, let's try, let's show, let's start to have these studies, or it has to be super regulated, as you say, with the medical blah, blah, blah.
I didn't understand the question actually.
So, maybe I'm not understanding well, no? But it's like seems that it has to be super well done, a lot of studies done to start. But what I have seen for palliative care is that we started giving little steps without being totally ready. The skills are, I think there are a lot of professionals.
Yeah, I guess that would be a good place to start, but I guess parallelly you can, start small, giving music to patients or at hospice or oncology settings. But at the same time, I guess it's very important, because as a doctor, when I say, give music to everyone, it might, again, as I said, there would be a lack of objectivity. So just to safeguard science, I think it's important to parallelly have that, slow process of research going on one side. But as I said, that's what I said. It's all it takes is one question, and you can ask patients if they would listen to some music during a procedure or otherwise, and play that music. That's fine. That's fine. But only thing is, you can't call it music therapy. It's a music sessions. Collaborate with musicians. I mean, I'm a musician myself, so there are plenty of bachelors and masters in classical music students coming out, and many of them are actively searching for some opportunities. So you can collaborate.
Thank you so much.